joke.
Great segue.
Good morning, everybody. Welcome to Grand Rounds this morning. It's a pleasure to introduce Dr. Nupur Bakshi, who is a medical retina and uveitis specialist who practices at Mount Sinai Hospital, as well as Unity Health, so St. Mike's and St. Joe's, as well as the Kensington Eye Institute. She has an all-star panel of people with her today, so I'm going to hand it over to Nupur to introduce everybody and get started with the rounds.
Thank you, everyone, and thank you for joining us early this morning. And special thanks to our resident presenters, Anish and Jenny, and to these amazing panelists. And I'll just put up my slide deck and then go through them in a little bit more detail. Great. Can everyone see my slides?
Yes.
Yes.
Okay, perfect. So today we are reconvening our mystery retina and uveitis panel. We did this about a year and a half ago, and it was very popular. We got a lot of feedback that all rounds should have this format. So we brought back our exact same panel together, which is exciting. So this is our panel. Thank you all of you for joining us. Is everyone actually on the call? Just want to make sure all of the panelists are on. Yeah, perfect. Okay, so our panelists are Dr. Ephraim Mandelkorn, Dr. Larissa Dursko-Duslinski, Dr. Kenneth Ng, Dr. Deepa Yoganathan, Dr. Panos Christakis, and Dr. Alex Kaplan. And so what the point of today's rounds is to really have a fun and lively discussion, review these cases, a lot of which are pretty complicated, but all of them have take-home pearls that are useful even if you're a comprehensive ophthalmologist, to review atypical approaches, atypical presentations of retinal disease and uveitis, and how to really approach them, as well as differential diagnosis and multimodal imaging. The residents are going to be very happy because they're not getting pimped today, the panelists are. So, they can sit back and listen, and the tables are turned. So we'll start with case one. This is a simpler case. I thought we'd warm up everybody and before we get to all the crazy stuff. It is a uveitis also panel, so I'm sure one case has to do with syphilis. There's never a uveitis panel or uveitis talk that does not have at least one case of syphilis. So panelists, look out, there's going to be something with syphilis. It's not this one, but there will be one. So this is the first case. This is a 20-year-old female who has sickle SC, and she was referred for screening by her sickle team, and she's 20/20 and she's asymptomatic. And there's the image of her OCT on the screen. I'll just have the panelists take a look at that. We won't comment on it exactly yet. And this is her fundus photo in the right eye. And again, I won't say anything. I'll let the panelists do the commentary. And this is the fundus photo in the left eye. So, and here are the fundus autofluorescence images. Again, there's obviously some evident pathology that's there. So I'm just going to go back to the OCT for a minute. Any thoughts from the panelists? Does this OCT look normal? Does anybody want to comment? What do you think of this OCT? Maybe Ken?
Yeah, there's a 20-year-old patient. So for a 20-year-old, the retina looks a little bit thin and atrophic.
So this is the right eye. I should just specify this is the right eye. Left eye looks similar.
Yeah, the choroid might be a little bit thick. You have a pretty normal foveal contour. You can see all the layers of the retina pretty well. The outer retina is preserved. She's got VMA, pretty formed vitreous. But the retina is a little bit thin as you go temporally and maybe to a certain extent nasally as well.
Okay, right, excellent. And then what about here? Let me show the affected eye here. Do we see anything abnormal here?
Hi, Nupur. The temporal retina in the left eye looks quite atrophic. So my standard protocol, in Detroit, we have a lot of sickle cell patients. So a typical standard protocol would be to get optos fluorescein angiography with steering, look for the NV, and then laser the ischemic areas.
Thank you. Perfect. So here is the question you're asking, is the OCT normal? And as Ken pointed out, there's especially this particular area of thinning here and maybe elsewhere as well. And here is your fluorescein. So this is evident area of ischemia that's out temporally, actually almost 360, and then nasally as well. And there's the area of neovascularization. And this is the photo in the other eye. There's some, signs of non-proliferative sickle retinopathy, but also very, very prominent ischemia that's peripheral. So, and then there's the area of neovascularization there. So Deepa, actually, could you elaborate a little bit more on, do you use OCT when screening these patients to guide who needs testing? Do you always laser all of them? What if they have ischemia without neovascularization? What's your preferred management?
Yeah, so there's a medical component of this and a sort of socioeconomic component of this. So first of all, yes, we do OCT. We oftentimes do find that temporal thinning that has been classically described for a lot of sickle cell patients. I think it's a nice tell. So for example, if it's a patient that we wouldn't typically do optos with steering, but we see on screening that there's that temporal thin area of OCT that automatically triggers me to look more in the periphery and maybe do some steering with the optos to look for those areas. To answer your question about how I treat, so someone who has 360 degrees of that ischemia, if they have NV, that's easy. Obviously, I would laser throughout that area. I would divide it up probably into 2 sessions. I don't want to overload them with 360-degree laser. If they had NV in one eye and no NV in the other eye, I would still laser, 360 degrees the other eye. I don't like to sacrifice the posterior retina. That retina is in good condition, so I do try to target to the ischemic areas. I would repeat the angiogram several months later to see if there's any persistent NV, and then continue to titrate the laser until the NV involuted.
And then do you find there's any role for anti-VEGF for these patients, or is it first to laser?
I try not to. I don't think it's necessary if you can get it with laser. I think that these patients are oftentimes young as well. So once I have them in the clinic, and we're talking about laser, oftentimes it does, scare them and it is painful. So I do like to laser them the day that I have them. And then sort of reiterate the follow-up, because I have had several patients that despite laser, a couple years later, their NV can, recur from new ischemia. So I do keep them always, in the system for serial FAs year to year, just as a screening protocol.
So excellent. So I think a really important point for comprehensive ophthalmologists these are patients that are young, 20/20 and asymptomatic. And this OCT sign with the temporal thinning is a really helpful sign that you need to really look more thoroughly in the periphery, because, if you quickly looked at this photo, you might think, oh, it looks pretty normal. And then maybe you'll see here that there's this sclerotic vessel running here, and then this isn't, totally normal, but if you were just examining them quickly, you might miss that. So really a helpful sign that's actually been studied in the literature and actually has very good positive predictive value for presence of proliferative sickle cell. Anyone else from the panel want to comment? I'm sorry, I can't see all of you at the same time, so just unmute yourself and chime in if you have any additional comments. Do you manage it the same here?
Yeah, I think most of us would treat if there was NV, but I think we have to keep in mind that the natural history can be quite good. A lot of these areas of NV will auto-infarct. So it's, we have a much lower African Canadian or African American number than what Deepa might see in Detroit. But it always astounds me how oftentimes we get someone who's traveled from Africa. They've got some, small vitreous hemorrhage. You look in, they've got almost 360 of NV, and it's all fibrotic, and there's very little active disease. So, not everyone does poorly. This is not nearly as bad as, say, proliferative diabetic retinopathy, where you get a lot of traction near the macula. Yes, they can get breaks, and they sometimes need to go to surgery. But even with relatively light laser, you oftentimes will see involution, because I think the natural history is fairly favorable.
I think that's a really important point, Ken, that it doesn't behave the same as diabetes. So even though they have that NV, they tend not to progress in the same way, and laser alone is enough. Any other comments before we go on to the next case? Just go right to the end. Okay, so we'll go on to Jen, who is the PGY4 resident and has 2 cases to present. Jen, I'll advance your slide, so just let me know if I'm not going at the right pace.
Hey, thanks. And so again, my name is Jen. I'm the PGY4. I'll be presenting a couple of cases as part of this panel discussion. I'd like to thank Dr. Bakshi and Dr. Christakis. So first case, I want everyone to meet Mrs. R. She's a 43-year-old healthy Caucasian female. And in terms of her medical history, nothing much, just a benign essential tremor, no ocular history. So she presents with 2 weeks of bilateral flashes, which she describes both centrally and peripherally. And these episodes are preceded by an occipital headache. No other major ocular symptoms, no floaters, field defect, pain, or redness. So on examinations, pretty unremarkable. You can see she's seeing 20/20, anterior segment exam, pretty normal. And if we go to the dilated fundus exam, here are the optos photos, nothing striking so much. You can see some artifact in the left eye from her asteroid, but like disc, macula, vessels look pretty normal.
And just to point out, this is an artifact because we saw it in all the photos. We were initially wondering if that was choroiditis, but it's an artifact.
And so an OCT of her macula was done. So you can see here we have the right eye, which there are some changes, and then here's the left eye as well.
So let me pause and ask the panelists here. Any thoughts on the OCT? What is striking you as abnormal here? And it's pretty subtle, so you have to look closely.
Yes, I can take this one. So the most striking thing is that when you look at the ellipsoid zone, we can start with the right eye. You can see that the kind of ellipsoid zone, as you come more centrally into the fovea, kind of just disappears. That line over there, and if you continue it, you can also see a little kind of subretinal deposits at that ellipsoid zone over there, and kind of a similar pattern in the left eye, a bit of like a moth-eaten appearance to the outer retina, maybe a bit of an enlarged choroid as well.
Mm-hmm. Yes, and then these focal excrescences as well as Alex pointed out.
And maybe if you,
and Nupra, you know what I would do in Windsor if I saw those OCTs.
100%. We're going to get to that, Deepa.
And by the way, I start ordering the treatment myself now instead of going through ID. Anyways, go on.
A little clue there, everyone. Okay. Okay. So this is the visual field, and Jenny, the patient didn't describe these type of field defects, correct?
No.
The flashes. But yeah. fairly prominent field defects, as we can see. Okay, I'm sorry, Jen, I'll let you take back over.
Okay.
Okay. So, everybody, what just on the basis of this OCT in field, Deepa had some thoughts here, so I'll hand it to you, over to you for a sec. So what do you think is going on?
So based on the OCT alone, I would suspect that this is a syphilis retinitis. This is a classic appearance of this ellipsoid a dropout in both eyes. I think they oftentimes present with atypical, asymmetric vision changes. They may be just slight blur, or they may have a lot of vision loss. And I find that it doesn't really correlate to when they develop their retinal findings. Most of the patients that I have treated for syphilis, now it's not that many, it's probably a dozen in the last year and a half, but that has been significant in my life to see it so often when I've never seen it that much before. So what I typically do on the same day is I do an autofluorescence. And the Optos autofluorescence shows beautifully a Mudes-like pattern in both eyes. And here, the fact that it is bilateral should make you think immediately about syphilis, bilateral Mudes. So I, ask them about, their history. And again, oftentimes most of the patients I've had are in monogamous relationships and would have never, ever thought that they have syphilis. They don't have necessarily any rashes or anything like that. Some people have shown me pictures of rashes that they've been treated in walk-in clinics with topical steroids. So sometimes you get a very telling history and sometimes you don't. I send them right away for screening, general uveitis screening, but also for syphilis screening. Unfortunately, public health is quite slow these days. in at least in Windsor, I'm not sure about Toronto, it still takes a couple of days to get back. I oftentimes have to call the lab to get the results myself. And now, based on this, we would send the patient to the ER for their first penicillin G IV dose. So that's 4 million units Q4 hours for 14 days. They have to get their first dose under monitoring by a nurse or a doctor, any first dose by IV. After that, they can go to an outpatient center like a CCAC. They get a little fanny pack with their medication, and it goes continuously around the clock. 2 weeks, I send them to for lumbar puncture as well. You can do a lumbar puncture even after you start treatment. So within the first week after you start the penicillin, if they get their lumbar puncture, it still wouldn't change the titers, the syphilis titers. I get them into ID, but ID oftentimes takes a month to see them. And then depending on their titers, they will watch their titers. So they want a reduction. I think it's like a 4-fold reduction in a serum. And then I can't remember if it's 4-fold in serum or in the CSF. Following the 2 weeks of penicillin IV, I may decide to add like an IM injection, depending on how their OCT looks and how their autofluorescence looks. And then I would add oral prednisone. I love how the prednisone kind of cleans up the last little bits of visual field changes and the autofluorescence picture and the OCT. And I find it gives like pretty nice results considering how badly their vision is affected. In terms of systemically, these patients look like they're brand new. You know, when you see them, they oftentimes they look cachectic. They look just not well. I think I've had out of the 12, maybe 2 looked like completely, you know, totally.
You should do a case series, Deepa. Close together.
Based on how they look. No.
Windsor seems to be the syphilis capital of Ontario.
Well, unfortunately, I did a rounds in Alberta, and the NICU is completely overrun with screening for syphilis, unfortunately.
Oh my God.
Yeah, really awful. Anyhow, so the patients, they feel like they're brand new. Like it's like they've been plagued by this disease for so long, but no one has diagnosed it, you know, because they maybe don't have any other symptoms that are very specific. So their hair looks great, their skin looks great, they're just like overall energy looks great. They look like complete, like to the women I saw, they look like models when they came back after the post. It's amazing. So
let's let Jenny continue with the case and see what happens. But I think we have our answer there.
Can I make a comment, Nupra?
Yeah, absolutely.
Just Jenny, do you mind going back to the color photo?
Where did it go?
Sorry, I'm going backwards.
There we go.
Slowing down. So I just want, we did teaching last night. I want the residents to look at the left eye infratemporal quadrant, and everybody recognize this is exactly similar to what we showed yesterday, where you have these punctate interretinal findings.
I think that was supposed to be an asteroid, Jenny, isn't that right?
Oh, is
or
it?
This is Panos, maybe you can comment, Panos, this was your patient, right?
No, it looks like syphilis to me.
yeah, there's those are actually little asteroid clumps there in the left eye, but definitely what you said about those interretinal things, that's very, very suspicious of syphilis. What's interesting about this case is that this lady was 20/20 in both eyes and had been complaining kind of flashes on and off for several months. You know, she didn't have the classic posterior placoid kind of appearance, but I think that was due to chronicity in terms of the kind of creamy, yellowish posterior placoid lesions. So it almost presented more like an outer retinopathy rather than kind of the classic posterior placoid presentation where you see this yellowish, creamy appearance on the fundus photo. You know, whenever you see this, you think, you know, azure or some, you know, you have this young white myopic woman, you kind of think, could this be an azure? Flashes, symmetric, centered around the disc. But what kind of made me very suspicious is that there were those little RP excrescences. So that's unusual. So with azure, usually you get complete loss or drop out of the IS-OS junction. It tends to be significantly more nasally and oftentimes spares the fovea. The vision is usually more affected in both these conditions, but those little tiny punctate RP excrescences is very kind of suspicious for syphilis. I echo Deepa's comments that there's definitely been a big rise. I actually saw another case exactly like this 2 weeks later. And so, it makes you really kind of wonder whether it's there's something more endemic going on. And the other interesting thing is all these patients have been perfectly healthy and like in monogamous relationships on review of systems, have been married with one monogamous partner who obviously has a bit of explaining to do at this point, but always make sure to order HIV as well, because my experience is oftentimes there's concurrent HIV in these patients, but very kind of interesting presentation.
So we'll just, we'll go right to the end there. Maybe, Jenny, can you continue from the next case, which Panos mentioned as well? And then I have a question for the panel after that.
So our second case is Mrs. S. She's a 37-year-old female, and like the first patient, fairly healthy, just has a history of migraine with aura, but she presents with a 3-month history of the central scotoma in the right eye and occasionally gets flashes. No other ocular symptoms that she describes. And on examination, you can see that vision is down compared to the left eye at 20/70. In terms of anterior segment, AC is deep and quiet. And then on dilated examination, which we have the photos of in the next slide. So we can see, I don't know if it's too evident here, but in the right eye, if we just click it one more time, there is 1+ vitreous cell and some trace haze in the right eye. And even in the left eye, where she wasn't describing any symptoms, we saw that there was trace vitreous cell as well. And again, OCT macula was performed. We can see the right eye and then the left eye as well.
So again, similar findings, although the left one looks better than that other patient.
Mm-hmm. Yeah,
but the right one has, again, that dropout.
So ISOS changes in the right eye and then subtle changes in the left. And then we can see the visual field as well. Left eye looks normal. The right eye, we can see that central scotoma that she was complaining about. And this
one was interesting because, central scotoma in one eye was actually initially referred to our neuro-ophthalmology colleague, Dr. Michelli, who very astutely recognized and diagnosed the syphilis. So, it could sometimes be sold as a neuro-ophthalmology thing if it's a central scotoma. So it's always in a little bit of disc edema, sometimes a little bit of vitritis. So always important to keep it on the differential.
I think that this is a pretty subtle OCT finding, especially particularly in the left eye, but even in the right eye where the vision is down. And I think it behooves us to be really careful when we're looking at these images with good resolution. And even if you look at the color printout, you might miss some of these changes on the OCT to look at it in black and white.
I also just want to point out too, sometimes the 5-line roster can miss things. And it can be very helpful sometimes to look through on the HD Cirrus viewer, the actual Mac cube, and slide through all of the images that you see something, because the 5-line may miss some of the findings you're looking for.
100%. And then test results. Sorry, keep going.
Yes.
Jen.
So a syphilis test was done for her, given her imaging findings, although this patient, again, was also in a monogamous relationship, but came back positive, and she was started on the neurosyphilis protocol that Dr. Yoganathan had touched upon earlier, and she was diagnosed with this syphilitic outer retinopathy. Upon further questioning in terms of her social history, turns out she had a vaginal lesion a couple of months ago and underwent STD testing for that, and then she talked more with her husband, and it turns out he had a syphilis contact with his ex-wife.
So before we go on to the next case, Deepa, you made an interesting comment earlier that you send them right to ER. So would you do that right off of the image of this OCT? Like, let's say you're seeing that patient in clinic and you have the OCT, and then I'd like to ask the rest of the panelists as well. If you just saw a patient with the OCT, the syphilis testing isn't back, is the OCT alone enough, or maybe the OCT and autofluorescence, depending on where you're seeing this patient, if you have the imaging access, would you send them right away without having the test result for the syphilis?
So the last patient, that the one that I did send directly for treatment, I sent her because it was a late Thursday night. So I know, and she was having this, the first patient you tested, you presented was 2020, so it may be different. She had vision loss and it was sudden and it was in the last 10 days. And she was very anxious about it. Not only that, when I said, you know, is it possible, the minute I saw the OCT, I asked her, is it possible that you have syphilis? And she said, no, but I'm going to kill him. And so, you know, I think she said, you know, then sort of, she's like, you know, it's possible he lied about this or that, you know, so based on that little social story, I said, okay, we have a choice. Either we wait 5 days, including the weekend, for the test results, or we send you to the ER. And if you get penicillin when you shouldn't have gotten, when you didn't need penicillin, then, you know, you've gotten
it's not the end of the world.
Right. And I did confer, I text with the even though the ID person specialist doesn't see them within a month, I text him all the time. So I texted him, I said, is there really a downside? He's like, no, not really. I think if you're clinically suspicious, it's okay. I want to make sure medical legally I have grounds. And obviously the patient and I had, you know, I felt like I trusted her and she trusted me. So it wouldn't be the correct situation for everybody, but with her, it was obviously the correct situation. And I give all you know, these kinds of patients my my personal email so that they can update me, because sometimes in the ER they may get lost despite multiple letters and faxes that go with them. So I want to make sure they're getting all the proper treatment, that they get their lumbar puncture, that they get set up for their PICC line after, and things like that. So absolutely, within 72 hours, her vision already got better, and her rash, oh, she had a rash also, and her rash on her trunk was completely resolved. So then we know, based without the test, we know that she's getting better from that. The IV.
Larissa, from any other thoughts, would you do you typically like examine these patients' bodies and skin? Any other thoughts on these cases?
I just want to make a comment about this is a small point, but maybe just a good teaching point for the residents. And that is, Jenny initially said the patient had photopsia, and this is one of the most common complaints that we all see in our offices. Patients often have flashes. I think it's important to ask patients to describe the flashes, because that actually, you know, a lot of these findings are subtle. You may not have autofluorescence or easy access, but one of the key points between, you know, normal photopsia that you'd see in vitreous degeneration would be that they're usually they're always temporal, and patients often will just give you like, sometimes they don't even speak, they just go like, where are the flashes? Then they just do this, like it's just this thing, which isn't, you know, it's always on the outside. It's always like an arc shape, and it's in the periphery. And if patients say they have central flashes, that should clue you in right away that this is maybe something different, like a white dot syndrome, or something like a choroidal inflammatory syndrome like syphilis. So Jenny initially said the patient had central flashes. Right away, you change your mindset. This is not just a PVD check. This is a uveitis case, and I have to make sure I'm cautious looking for these findings.
I think that's a really excellent point, Ephraim. Thank you for highlighting that. That's really important, because yes, if we saw this patient quickly in our office, then we might just think, especially if she was a myope, we might just assume that this is a vitreous syneresis problem. So really important findings there. Larissa, any other thoughts?
I was going to ask Deepa about the prednisone that you say you use most of the time. I haven't always used prednisone in syphilis cases. It sounds like you see more syphilis than I've seen, though. But
that's funny that in Windsor she's seeing more than we were seeing in Toronto.
I mean, if they improve so much, and that is typical of, you know, once they start their penicillin treatment, they're dramatically improved their eye condition. I mean, what are do you always use prednisone, or are there certain reasons? I mean, if there's residual inflammation, or at what stage do you use prednisone? How much prednisone do you use? I'm curious.
So at the end, basically I have them imaged with OCT and autofluorescence weekly. And at the end of the 2 weeks of penicillin, I find that there's still, you know, there's sort of retina left on the table, if you want to say. I know that the penicillin will continue to work even after we stop. But first of all, another important point is it's supposed to be 14 continuous days. If there's interruption in time, according to ID in Windsor anyways, you're supposed to restart the clock. So that's one thing that to monitor. I find that there's still, at the end of 2 weeks, I don't find their autofluorescence perfect, and I don't find their OCT perfect. But I do find that that adding the prednisone helps with the last bit of inflammation. A lot of this I learned from one of my fellows from last year, actually, one of my Kresge fellows. She was a uveitis specialist at the NEI for years. And so when she came to us as a surgical retina fellow, I learned a lot of uveitis from her. And so that's what they do over there at the NEI. And she's the one who told me to look at the OCT, those excrescences, to see that it should clean up really nicely. And so if you're looking for that reestablishment of the ellipsoid, it does happen after. I find that it happens better with the prednisone, the oral prednisone.
And Deepa, with the prednisone, does it just hasten the improvement, or do you actually get a better final outcome, do you think?
Yes, for sure. I think it's a better final outcome.
1 milligram per kilogram, is that what you're?
Yeah, usually about 60 milligrams, and I'll do it for 2 weeks and then stop.
So Panos, any thought, how did this patient do? I don't know if you have further follow-up yet, or if you've just seen them recently.
So both patients ended up doing well. So I saw her actually just yesterday, and vision had improved to 20/25 in that affected eye. I agree with Deepa, like if there's still pronounced vision loss afterwards, you can consider steroids. It's pretty amazing how that ISOS reconstitutes. In both these patients, they didn't require it as a result of having good vision and good response to the penicillin.
Thank you. So always a lot of discussion on the syphilis cases. Even if we do nothing else, we have met our objective of having done one syphilis case on this panel. Any other thoughts? I'm just going to move to the next case in the interest of time. So this is a patient who was referred to me for non-resolving panuveitis. He's a 38-year-old man who decreased vision and floaters for 18 months in one eye and floaters in the other eye for 3 months. He'd been managed by the referring specialist with topical steroids and oral prednisone, a short course, higher dose for 2 weeks and then taper. He actually had a subtenon Kenalog injection prior to the first visit. His history was unremarkable. The referring doctor had done workup as well, which was basically normal. He was 2100 in the right and 20/20 in the left. And this is what he looked like on exam. So a whole lot of vitritis in the right eye and maybe some lesions underneath, but it's very hard to see. And the other eye looked pretty good. Maybe there's some temporal changes here. Some look old with pigment and perhaps some that are newer, but certainly not the same degree of vitritis as in the first eye. And then this is what his imaging looked like. So his fluorescein, it's not so useful out of the right eye because of the vitritis. And here's a little bit further close up on the left eye with these lesions that are evident, and then just a more zoomed picture with the OCT through this area as well. So any thoughts here from the panel?
Sorry, Nupur, how old is the patient?
He's 38.
And ethnicity?
South Asian. It's not TB. I'll just say that. Okay, it's not TB.
Can you describe the prednisone taper that he went through? Like how long was he on steroids for, and how quickly was he tapered?
He was on 50 milligrams for 2 weeks and then like a taper down to 10, and he was on 10 for like 8 months or 6. It's quite a while.
And when he was on 50, he was responding well, or he had this partial response the whole time? Very partial all the time, even at the high dose. And 50 was not fully 1 milligram per kilogram, but pretty close. Yeah, so I guess in general, if someone's having a partial response to steroids, you should try to rethink your diagnosis in terms of infectious, other types of masquerades, neoplastic causes as an alternative diagnosis. His review of systems was, I mean, he's a younger person, so maybe neoplastic is a little bit less common, but did he have any other symptoms that would suggest otherwise?
Nothing, just that he couldn't see. Yeah, but I think that point that you're making, Alex, is a really important one. When somebody doesn't respond, as unfortunately, we can usually throw steroids at most people once we know it's not infectious, or we think it's not infectious and it should work. And if it doesn't, then we have to wonder what's going on.
And you said his uveitis workup was negative, but what did that consist of?
It was done by the referring provider, but it included basically the standard like syphilis, of course, the TB testing, the chest X-ray, some routine blood work, HLA testing, like HLA B27, not more thorough than that. It was referred by someone in the community, so they didn't do like a full panel or highly detailed, but and an ACE test as well. ANA and rheumatoid factor, I think those are the general ones that
was
were
a
done.
vitreous biopsy considered?
Excellent point, Deepa. Yes, so not yet. This was referred from the community, so that is something that we were thinking about there at this point once we saw this patient. So as a steroid non-responder. Yeah.
There's I want to point out a few features that may be important in this case. In the color fundus photograph, I don't know if you can zoom in on that, but in the left eye, there are the lesions that is kind of deeper retinal or choroidal lesions. Some are there are variable sizes. There's some pigmentation around them. There's a pattern that I'm suspicious for. I mean, we can't see so well in the right eye, but in the left eye, you can see it in the supratemporal region there. So that may be a bit of a kind of a leopard pattern appearance. I'm not sure, but it is suspicious just on the color fundus photograph. And on the OCT, there does seem to be some choroidal thickening on the OCT that you've shown beside it.
Yeah, so I think those are all excellent points, and everybody's spidey senses is twitching right now because of the features of this case. So we did order additional labs for this patient. We did restart prednisone at 1 milligram per kilogram just to see, like, was it that it was subtherapeutically treated because he wasn't fully at 1 milligram per kilogram. But, I said off the bat to the patient that we have to make sure that we're not dealing with something else. And he was referred for diagnostic vitrectomy.
Were there cells in the left eye as well? I didn't catch that.
Yes, there were, but not a severe degree, like not like the right. There was some vitritis there as well.
Yeah, I mean, the optos can give you a lot of artifacts, but there's a lot of vitritis in the right eye, more so than you would expect with sort of a regular, uveitis.
Yeah, 100%. Like that is a lot. There was a lot. That's actually quite accurate as to what his exam looked like. The color is off, but it actually did look like that.
What's the vision in each eye?
It was, I believe, 2100, which is surprisingly good for that appearance, the right eye, and 20/20 in the left eye. And so we did the diagnostic vitrectomy, and that came back as a bit of a surprise given his age, but it came back as peripheral T-cell lymphoma. And so, this patient also had ended up having positive CSF, ended up starting systemic therapy. And unfortunately, this is now, I think, about 3 years out, and he's since passed. And the initial diagnosis was from the eye. So just a sad case, but an interesting one of wanting to think about if patients don't, as Alex said right off the bat, if patients don't respond as you think they should, really reconsider the diagnosis. Because steroids usually work if it's not infectious. So any other thoughts on this one before we move to Anisha's case?
I just want to make a comment of how the decision making to get to vitreous biopsy. Just some general pearls about vitreous biopsy. Schedule it earlier in the morning to communicate with the pathologist, communicate with the lab, make sure that all your labels and your media are exactly what they want. I find it kind of a orchestration of sorts whenever, maybe it's more streamlined at the downtown hospitals, but I find it.
Coordinating with the lab in advance and making sure you take all the tubes they want and it's the sample is they're ready in the lab. I think to process the sample is certainly important. Ken and Ephraim, you guys would be more likely to do the vitrectomies for these patients. Any additional thoughts on that?
No, I think communication is key. Reach out to the pathologist, make sure you know which technologist it's going to. In a lot of these big hospitals, I mean, the lab is quite a labyrinth. So it's nice if you can have someone run it down to the exact room in person, so that they can process the sample right away. And in the old days, they always used to talk about giving them an undiluted specimen. I think that's not so important. And in a young phakic patient, it can be challenging. You've got the lens, so the eye collapses as you start the vitrectomy. And then, practically they spin down the specimen. So there's no need for them to receive an undiluted specimen. So these days we leave the infusion wide open. I draw the specimen out of the aspiration tubing from the cutter, and then we send it right away.
I think it's also important to talk to the cytopathologist ahead of time. So there's at St. Mike's, where Nupur and I are located. So we know the cytopathologist. So giving them a call, kind of corresponding with them ahead of time, letting them know there's a sample coming. So that they can process it immediately, they can have their lab process it immediately. And they're often very interested in these cases. So they don't see these cases very often. So again, communicating with them afterwards, it helps to make sure they're processed properly. And that collaboration between multidisciplinary collaboration is also very effective, and everybody appreciates it.
And I think the other important point too is that even though this is a masquerade and this ended up being a neoplastic process, the patient still had a partial response to steroid in the beginning. So, having a partial response, just as it should make you reconsider the diagnosis, doesn't rule out a neoplastic process either. So,
I'm not sure if a multiplex PCR is available in Toronto, we do have that at Kresge, and it's really. It's so wonderful. We just walk up. We can do an AC specimen or a vitreous specimen before getting to vitreous biopsy stage. Walk it up to the lab. Within 4 hours, we have a PCR results of whether it's virus, fungus, or bacteria. So in terms of ruling out virus before going to vitreous biopsy, I think that's a nice in between and less invasive.
Yeah, I haven't seen that done. I don't know if you guys have noticed that in any of the other hospitals.
I mean, we do a multiplex PCR no, it's not so right. It's not so quick. They do ask us to indicate. I mean, if we truly think, do we think it's primarily CMV or HSV or HZV? But if there's enough sample, they'll run all three on the PCR. I thought you were going to say you have a PCR to look for cytopathology, like they have the IgH gene rearrangement, and I think it's a MIC88 or there's a few PCR tests, but yeah, we're not quite that advanced.
No. This is just the simple diagnose, like which virus, and you need a tiny little amount because of the PCR for this, as opposed to if you give it to
like 16S, like the 16S
the ribosomal
pan-bacterial, pan-fungal.
Public health does do that. We'll do that.
Yeah. For whatever reason,
how much do you need? So
I think the volume is quite high requirements. I don't know. I've never ordered it here.
So let's just given the time, I'm going to ask to move to the next case. So I love the discussion. That's amazing. Thank you, everyone. So Anish, you're up for case 5 and 6. Anish is one of our stellar PGY5 residents. So let's get going. Okay, and I'll advance the slides and let me know if I'm not going fast enough.
Special thanks to Dr. Bakshi for her guidance and the panel for their insights. And we'll just continue the rapid fire uveitis cases. So we have a 19-year-old Black female who presented to the ED with a 4-day history of progressive right eye pain, photophobia, headaches, and blurred vision. A week prior, she also noticed some metamorphopsia. Past medical history, she had fibromyalgia, no past ocular history, and some allergy to penicillin. On examination, visual acuity was 20/60 in the right eye, 20/50 pinholing to 20/20 in the left, no RAPD and normal pressures. We noticed a 1+ conjunction in the right eye with 1+ AC cells, and then in the left eye, half plus AC cells. So draw your attention to the Optos photos. We can see normal nerves and vessels in the right eye and left eye, but you can see these obvious multiple white placoid lesions focused mainly in the posterior pole. And that's involving both eyes. And we'll advance to our OCT nerves. You can see some mild elevation of the right RNFL, but otherwise normal. The MAC OCT on the right side there shows subretinal fluid in both eyes with an obvious large basilar detachment in the right eye, which was actually a little bit off center there, but we'll look to the autofluorescence now. Next slide there, thanks. So this shows generalized hyper-autofluorescence throughout the posterior pole in both eyes, with a few hypo-autofluorescent spots, again focused in the posterior pole. And then we'll move swiftly to the IVFA. So we can only get the early phase in the right eye, but you can see these obvious early hypofluorescent lesions. And then if we advance again to our later phase, you can see late staining and leakage around those lesions as well.
Maybe we'll pause there and ask the panel to comment. What do you guys, kind of what's coming to the top of your list? What do you think might be going on? Or what do you want to do? Anybody want to just unmute yourselves and chime in?
So it looks like active choroidal lesions with the early, so the hypofluorescence and then later hyperfluorescence. So, I mean, there's a pattern here that we're suspicious for, given the placoid type lesions in the posterior pole. Variable sizes. So, I mean, we would obviously, just looking at this pattern on first thoughts, I'm thinking AMPI, but we would need to also rule out other uveitis diagnosis. So we do a full uveitis workup in this case, and we want to do a review of systems, ask if there's any systemic complaints, specifically any neurologic complaints as well.
Why is that, Larissa?
So if it is AMPI, we're thinking, I mean, that can also present with headaches, and it may be related to a CNS vasculitis. We want to, so I mean, obviously, field review systems, anyways. I mean, and we're thinking, so how do we start narrowing down the differential diagnosis? But of course, we want to ask for, you know, we want to look at, could this be syphilis? Could this be TB? Could this be any other diagnosis? So we would send patients for a workup, kind of regular investigations for uveitis.
And then I think that that point you made about the fluorescein, so for residents, pointing that out again, this originally these lesions are blocking early, and then they're staining and leaking late. So that's an important, you know, fluorescein description for choroiditis. So what we think is going on, Larissa kind of summarized exactly what the plan is next. So you want to take back over?
Yeah, so we did a full uveitis workup. We started the patient on Durezol, Nevanac, and Cyclogel, and like we were discussing, we were thinking of this patient has a bilateral panuveitis with a chorioretinitis. Top of our list was obviously AMPI. We were considering VKH, but you don't typically get these white lesions. MUDES, these are probably atypical for, these lesions were atypical for MUDES. Birdshot, we've got a younger patient here, so it's not high on our list, and then multifocal.
Well, what do people think about that OCT? I mean, there's a fair bit of fluid. I mean, I'm no uveitis specialist, but with AMPI, I don't really think about subretinal fluid so often.
That's a good question. Anybody else want to comment?
I completely agree with what Ken said there. You know, you can get subretinal fluid in AMPI, but it's very rare. I definitely would put VKH up there on the differential. You see these choroidal lesions, and they seem kind of unusual for VKH, but I've definitely seen it, and it kind of reminds us that we like to lump these patients into certain individual categories, both for research purposes and for kind of diagnostics, but it really is kind of a spectrum. And I have a patient who was a young gentleman who looked very similar to this, and ended up being a VKH patient. He was a little bit easier because he had some of the other kind of neurological symptoms of VKH. He had, you know, hearing issues. He had some depigmentation and other things, but it just kind of reminds us that these white dot syndromes are really a spectrum, and oftentimes you could grab from two categories. You could have features of both. So you could have AMPI-like features. You could also have VKH-like features. And obviously important to know because the treatment is obviously very different. You know, VKH tends to be more chronic, tends to relapse with prednisone taper. AMPI tends to be kind of more of an acute thing. You know, those lesions, whether they go away or whether they pigment is going to be a big, you know, differentiating feature between choroidal lesions associated with VKH that oftentimes go away versus the ones that you see with AMPI, which tend to pigment. The exception being those little Dalen Fuchs nodules, but those look a little bit different because they tend to be kind of subretinal excrescences, and they tend to become very small, punched out lesions later on. So it just kind of is an interesting case.
Panos, if this was more of like a amphigenous versus a straight AMPI, do you get more subretinal fluid, or no, they both would not have that much subretinal fluid?
Like I said, I think it's rare to get subretinal fluid in AMPI. It's definitely been reported. Like if you look up case reports, it's definitely been reported, and it kind of makes sense. You get RP dysfunction, but if you look at that FAF, there's even guttering of fluid under the arcade in the right eye, which is, you know, a little bit suspicious. It suggests like maybe a little bit more chronicity. It's like, you know, you can kind of see these areas of hyper autofluorescence that extend down below, kind of in this little guttering pattern, suggesting a little bit more chronicity. And when you see positional subretinal fluid, you kind of get a little bit suspicious.
The other thing which we couldn't pull up a great image of is that there was actually a little bacillary detachment on one of the little pockets on the OCT. And so as is known, those are typically seen in VKH1 and then certainly are reported in AMPI as well. And as Pano said, like these, we artificially separate out these diseases, but many of them overlap. In this particular scenario, it's important because the treatment is different, but many times when they overlap, it does, it's kind of semantics because the treatment is the same with steroids. But
there are a few other things, though. I think if we're thinking VKH, sometimes we actually, so early on, we may not see a clear subretinal fluid on fundus examinations. So just apart from all these fancy examinations, but when in VKH, often we see kind of these bubbles of subretinal fluid, and that is different than what I've seen in AMPI. Although you can get subretinal fluid like this in AMPI, and it does show by, I looked at the Mayo's AO manual. So that is fairly, I don't know if it's completely typical. I haven't seen it all that often, but it definitely shows up, the subretinal fluid. And yes, it's a continuum, but often on VKH, you can actually see the subretinal fluid on fundus examination, like bubbles of subretinal fluid before you get the big detachments. The other thing you get more of is you got a bit more optic nerve inflammation with VKH. So that's not in all cases again, but that's something that might lead you more towards a diagnosis of VKH.
So let's see what happens.
The other thing is, do we have the OCT? Because another differentiating feature is in VKH, you'll get a very, very thickened choroid. Whereas in MUDES, they tend to be kind of myopic patients and tends to be a thinner choroid. So I didn't take a quick look there before, but if you just go to the OCT, you can see.
We just have this cut. We should have added the 5 line with the deeper one.
Yeah, so there. If you look at the OCT there, you could see there's a very thick choroid. You can't see any kind of differentiating, features deep. That kind of black choroid is very kind of pushes me more to a VKH diagnosis. When you see that because it's like thickening and edema of the choroid. A B scan would be helpful as well, but a thick choroid goes more with VKH. With MUDES or AMPI, usually they're myopic, so they have a thinner choroid. But obviously, you could see, people with AMPI with thicker choroids too.
So we'll go let Anish take back over. So what happened next?
So at this point, we felt that AMPI, with the negative workup there, at this point, we felt AMPI is the most likely diagnosis. We ordered an MRA of the brain, which is really important, as we discussed, to rule out a cerebral vasculitis, which this patient did not have. Over the coming weeks, visual acuity improved to 20/20. She did have a slight steroid response, and that was managed topically. The AC reaction also improved, and the fundus displayed improved placoid lesions. And then OCT also showed some resolution of the subretinal fluid.
So this is with topical therapy alone. Let's just
only topical therapy, yeah. So patient was doing much better, and so we thought happy days, right? So the patient was supposed to taper to Predfort BID and Nevanac, but she stopped all her drops. She had informed us that she'd been seeing a homeopath who recommended exercise training and plant-based dietary changes instead. So she now returns complaining of mild blurriness of vision, floaters, flashes, and halos. Visual acuity was 20/30 and 20/20. Pressure was fine. Some rare cells in the anterior segment, and we'll go to the fundus photos. And so you can see here, if you compare to the other images, you can see in the left eye, you can appreciate these new placoid lesions kind of around the superior arcade there. And then if we moved forward to the autofluorescence, we can appreciate these new hyper autofluorescent lesions superiorly as well.
So what would you guys do now? So a good debate on, is this VKH, is this AMPI? I think because the patient, we started them on topical and they got better, and she got to 20/20. I mean, that's fairly unusual with VKH. I think it's that kind of pushed me. Almost the way the patient responded to treatment helped clarify the diagnosis a little bit for me in terms of thinking this is more likely to be AMPI rather than VKH. But now she's come back. She's on this diet and lifestyle modification, which is, there's nothing wrong with a plant-based diet and doing exercise. Those are all good things. But now has recurred because she stopped her medication.
Can I make a comment? I just
to
go back to earlier, and this actually relates to the recurrence. If you look at the differential diagnosis that was given earlier, the angiography shows block-early stain late, and I think that's pretty typical for AMPI, serpiginous, and multifocal choroiditis. You start bringing MUDES into the differential diagnosis. MUDES is a stain, it's hyperfluorescent early and hyperfluorescent late, And I think VKH, maybe there's a little bit of hypo early, but generally it's like a CSR spot where you get
more lesion.
Thousands of smokestacks everywhere leading to a detachment or like a massive CSR. So I don't know if I would put that. I mean, I see the points about VKH and the choroid and everything when the OCT, that's reasonable. But now that we have a recurrence, you're sort of now entering the realm of AMPI, which usually would be a little more self-limited, and then you have the serpiginous side of it, which is more recurrent. And for the residents who have heard the term amphigenous, you have to think of that at this point. And the difference really with amphigenous, and it's also known as relentless placoid, they're synonymous, and basically it's an AMPI situation where you have these plaques. It's like a white dot syndrome where their plaques are on the larger size, which block early and stain late, but it becomes a recurrent issue versus AMPI, which would usually resolve and not have this recurrence issue. So I'm thinking you're probably looking more in the amphigenous realm. It's not really serpiginous, which typically extends from the optic nerve and has a serpent-like shape. This is placoid, but it's relentless. So you have to start thinking about management, something more systemic, because it's becoming a recurrent problem.
Ephraim, when you're trying to decide on systemic treatment for relentless, would you expect more scarring at this point, more permanent blockage, or it's still too early because it's only the first recurrence?
Yeah, I think Panis alluded to this earlier. You probably would look at the spots late and see that there's pigmentation within the spots when it becomes more inactive or it burns out from its active phase. And maybe we haven't really seen that evolution yet, but I think ultimately, yeah, you get a wipeout with, because keep in mind that in AMPI, the inflammation is usually interchoroid or to the RPE, basically. It's basically RPE. So any kind of choroidal or outer inflammation that gives you inflammation in that region will disturb the RPE, and you get clumping of RPE within the spots, as opposed to something like birdshot, for example, which was also on the differential. But in birdshot, you wouldn't see spots at all on the angiogram. It's on the differential, but it's not really in this case because there's no spots on the FA. Actually, it's completely it's blanket normal. In birdshot, you get a vasculitis, and because the spots in birdshot are middle choroid, you actually don't have any disruption of RPE at all. So late the spots when birdshot burns out have no pigmentation. The RPE usually is not fully disturbed.
Unless it's not treated for a long time, then you can kind of see.
Yes, correct.
So I think those are really, really important points, Ephraim. Thank you for bringing that up. And I think we're going to see how this patient evolves because these are recent visits, like some of these imaging are from the last few weeks. So I'm just I don't want Anisha's last case to get cut. So we're going to move ahead here. Basically, the patient was very gung-ho about her kind of holistic regimen that she was on and wasn't keen to do anything else. Sorry, Anisha, go take over again.
So we discussed the patient treatment trials, steroid, PO, or posterior subtenon Kenalog. We agreed to monitor the topical agents because she was adamant her homeopathic treatment was the reason for her improvement. So we agreed that Lotemax, Combigan, and Azopt was a good happy medium. So in her last follow-up, the patient was doing well and stable in the right eye, and resolving placoid lesions were observed in the left eye.
And we'll basically have to see where she goes, and perhaps if she keeps flaring, then she will be more amenable to further treatment. But right now, she's wanting to try the conservative homeopathic management for first line. So I'll have Anish go to the next one.
We'll jump straight to the case 2. So we have a 60-year-old Asian female referred with a 1-day history of blurred vision in the left eye with associated flashes. Of note, the patient had been treated with oral prod over the past year for a mixed connective tissue disease and initially pulsed with IV solumedrol. Past medical history, she had dermatomyositis and was concluded she had mixed connective tissue disease as she suffered from oral ulcers, a rash, vasculopathy, and polymyositis, penicillin allergy, and was currently taking azathioprine 100 milligrams. The next slides. Visual acuity is 20/20 in the right and 2200 in the left. No RAPD, and the pressures were fine. Right eye also was within normal limits, and the left eye showed a 2+ anterior AC cell with a 3+ anterior vitreous cell, but no haze. So we'll go straight to the imaging. The right eye is normal. The left eye shows a diffuse retinal exudates and hemorrhages in a branching pattern extending from the nerve out to the periphery. And we'll go to the OCT next.
And along the vasculature, along
the vasculature, yeah. And then we'll go to the OCT, which shows a generalized retinal edema in the left eye when compared to the right. And when we focus on the left, we can appreciate a large pocket of subretinal fluid with an overlying hyperreflective foci, with multiple smaller hyperreflective foci surrounding it. In terms of the IVFA, which shows leakage from the sheath vessels with a large zone of peripheral non-perfusion.
And blockage from some of the blood as well.
And that's correct, yes. So if we want to invite some comments here.
Commentary here, and we'll go back to this kind of striking fundus photo here. Any thoughts, guys? So, okay, let's...
Pretty impressive appearing frosted branch angeitis there. So I think definitely, you know, it being an inflammatory etiology is a diagnosis of exclusion. There are definitely CMV variants that you can get that have this appearance. So that's something you obviously want to rule out with an AC tap, looking for viral PCR, because you can get kind of unusual viral variants. But the patient wasn't immunosuppressed or have any.
She's on azathioprine.
Yeah.
Okay, so she is immunosuppressed. Yeah, so I definitely would you know, want to rule out CMV, although it being purely unilateral, the other eye being completely normal, and that affected. I mean, you can get unilateral CMV, but you know, it's a little bit more unusual. But definitely, like an AC tap to look for viruses, I think would be helpful.
I would also keep leukemia lymphoma on the differential because of her immunosuppression.
Mm-hmm.
And she has connective tissue disease, correct? Like she has lupus.
Yes, she does. She has, right. She's got mixed connective tissue disease. So
at best, it could be just that.
Yep, absolutely. Anish, you want to proceed?
Yeah, so we suspected frosted branch angeitis. We AC tapped for viral PCR. We initially started a treatment of intravitreal ganciclovir and oral valganciclovir loading dose. We sent a full uveitis workup and it consulted ID and rheumatology. So so the infectious workup returned negative and the AC tap was negative. She was positive for anti-double-stranded DNA, anti-nuclear antibody, and ANCA. So the patient was showing no response from our antiviral therapy that we'd given. And with the above results, we had started the patient on oral prednisone 60 milligrams.
So I guess the kind of discussion that we wanted, and sorry, I need to keep going. We'll come back to the discussion.
Oh, yeah. So after 1 month, we can appreciate the resolution of the subretinal fluid and that larger hyperreflective foci in the left eye. And then we'll go over to the Optos and IVFA. And we can see an improvement in the retinal hemorrhages, almost full resolution of the exudates with no leakage shown on the IVFA. So at her last visit, she had actually improved down to 20/40. So she's doing well.
So just, I think, a really interesting case in that the patient is immunosuppressed, but she also has a systemic autoimmune disease. So she's got risk factors for both infectious etiology and for the inflammatory etiology. So when you guys see a patient like this early on, how do you approach it? Like, would do you think it was the right call to go ahead and treat for everything? Should we have just tapped and then waited? I got to look smart because I got referred this patient after the tap came back negative. But so VR was managing this originally.
I think you always have to put viruses early on. I mean, that's the urgent thing. So, I mean, even before the PCR comes back, I mean, most of us would start treating right away. So I think that was smart. With the negative tap, I oftentimes will repeat the tap just to make sure it wasn't a false negative. And it's interesting that you would have someone who would respond to a relatively small dose of prednisone, even though they were on Imuran to start.
Yeah, she's very petite, so that was fully 1 milligram per kilogram or just above that.
Yeah, I agree with exactly what Ken said. I would have done the exact same. I would have treated her for viral, especially with it being immunosuppressed and having risk factors for CMV. I'd be interested to just make sure that the blood serum CMV, look at the levels there, because if you have high CMV levels in the blood, then that obviously skews things a little bit. But I think the management was very appropriate.
Yeah, and she had an ID specialist. She was at a community hospital, and then an ID team here at St. Mike's was following her. I think that actually, how would you guys say, like, we always, whenever the residents hear about frosted branch angioitis, it's always thinking, oh, rule out viral. I would say the majority of the time when I've actually seen it, it's inflammatory. What has your experience been? Anybody has?
I have a case exactly like this, unilateral frosted branch, striking photos like that too, that also ended up being inflammatory. But yeah, I mean, I haven't seen like a classic bilateral frosted branch angioitis that was infectious like the ones you see in the textbooks, just because HIV treatment now is so effective and there's kind of a system to get these patients treated and seen. That's just been my experience.
Any other comments on this case from anyone else? Okay, so thank you, Anish. We have 4 minutes before we're forced to log off, so I'm going to skip my last case and then just kind of go to the end here. So really, just to summarize, multimodal imaging, as you can see in all of these cases, has been really important to diagnosing either rare diseases or atypical presentations of common diseases. And as we saw in these cases, if we always want to look at infectious and neoplastic causes and always keep that at top of mind. And if treatment isn't what we expect, to reconsider the diagnosis. Sometimes also it involves revisiting established diagnoses. I mean, sometimes when we see that same title for like follow-up, whatever the disease is, that gets propagated through every visit of the chart. And it may be years before we sit back and say, oh, you know what, it's actually not this condition that we just said it was every visit, because we made that assumption from where it was diagnosed early on. And certainly with these uveitis, many of these uveitic diseases, the diagnosis can become more evident over time. So for like that patient with the, AMPI and what's happening now, over time, she may end up being amphigenous or relentless placoid. Over time, that the presentation can change and the diagnosis can become more clear. And I think, as is critical in all of these cases, relying on your team is so important. Certainly, I think it'd be very hard to care for these patients without having help from multiple other specialists within ophthalmology, as well as internal medicine, ID, and rheumatology. And so I think this is really especially highlighting the team approach. And I just want to thank our residents who did a fantastic job presenting these cases, and a special thanks as well to our panelists, Deepa, Panos, Alex, Ken, Larissa, and Ephraim, for amazing commentary. I think we could have kept chatting for another hour or so. So maybe we'll have to see if we can find extended time in the future, but or we'll be back for round 3 of this in another year. So thank you so much. Thanks to the department for letting us present today.
Thank you, Nupur. That was fantastic, and we'll definitely take you up on the offer for another session. Those are great cases, great images. So thank you for putting that together, and thank you to Anish and Jenny, as well as the entire panel. You guys were awesome. So thank you all. We should also acknowledge that today is Remembrance Day, and thank all of our veterans for their service and their sacrifice on our behalf. So please keep that in mind as you go through your day today. We are a little bit over, so we'll end rounds now, and I'll look forward to seeing you guys next week.
Thank you, everyone.
Thanks for having us. Thank you for organizing, Nupur.
Thanks for organizing.
Yeah.
That was great, Nupur. Thank you.
Thank you.